everyone. First of all, I would like to thank the organizer of this meeting for giving me the opportunity to present my research and you for being here. Well, over 450 monogenic causes of neurodevelopmental disorders are currently known. A significant portion of them can be attributed by a disruption in the synaptic physiology, which is essentially the brain fails communication with others. Specifically, we will talk about the glutamatergic synapses, which is the main excitatory pathway of the brain. And the most prominent and representative of these alterations are defects of the NMDA receptor. This is the NMDA receptor, as you know. They are channels, mostly composed by the assembly of two mandatory GLUN1 subunits encoded by the GRIN1 gene, and the combination of two GLUN2 and/or GLUN3 subunits encoded by the GRIN2 and GRIN3 gene. For the proper functioning of this receptor, it is needed the simultaneous binding of some molecules that we call coagonists. They are glycine, D-serine, and glutamate. To date, only GRIN1, GRIN2A, GRIN2B, and GRIN2D pathogenic variants have been associated with disease. And clinically, these neurodevelopmental conditions englobes a spectrum of neurological and extraneurological manifestations, including intellectual disability, hypotonia, movement disorder, epilepsy, etc. Moreover, as we were learning yesterday, these variants can lead either to gain or loss of function of the receptor. So the knowledge of the physiology of this receptor and the stratification of GRIN variants as loss or gain of function are crucial to determine a personalized therapies. And in fact, as a proof of concept, our group characterized some years ago this GRIN2B variant as a loss of function, and they demonstrate that this variant can be partially rescued by means of elevated dose of D-serine. And more importantly, they demonstrate that L-Serine dietary supplement can improve motor and cognitive function in a 5-year-old girl with a loss of function GRIN2B related pediatric encephalopathy. So after this N-of-1 trial, we decided to carry out the first clinical trial in GRINpathies, evaluating tolerability and efficacy of L-Serine in patients with GRIN-related encephalopathy. This is the clinical trial identifier. And here you can see the study design. There is a phase 2A study with a single group assignment. That means that all participants receive L-Serine as treatment, and any patients between 2 and 18 years old could be included in the study. The study duration per participant was 15 months, and all participants received L-Serine supplementation during 12 months. During the first 3 months, they didn't receive L-Serine, trying to ensure that the potential benefits are due to the supplementation and not due by the normal neurodevelopmental progression. About those, patients received during the first 2 weeks 250 milligrams per kilo day of L-Serine, and after the third weeks, we increase up to 500 milligrams per kilo day. But if you remember the first graph of the NMDA receptor, we learned that the active form that activates the receptor is D-serine. D-serine acts as the neurotransmitter. But I mentioned before that we are giving to our children L-Serine. So why? D-serine is first, it takes longer time to diffuse to the blood-brain barrier, and more importantly, this serine is nephrotoxic. That's why we use L-Serine. And in our brain, we have an enzyme that is the serine racemase that promotes a locally conversion of L-Serine into D-serine. And in contrast to D-serine, L-Serine is a nutraceutical product that has been approved many years ago by the FDA and the European agency. And we have a lot of experience in pediatric care with L-Serine because it has been used for many years in primary defects of the biosynthesis defects. And in the last year, L-Serine was used in many clinical trials, such as in the ALS for the hereditary sensory and autonomic neuropathy type 1, in diabetes, and in Alzheimer's. So we feel confident about its safety profile, and we know that side events are minor. So after that, for evaluating the functional and cognitive abilities of these children, we use a variety of tests assessing the adaptive, the cognitive, the quality of life, and the motor function, as well as the behavioral, social, emotional, and sleep aspect. We evaluated also the epileptic aspect using the epilepsy diary and the video electroencephalogram. And for evaluating safety and tolerability, we based on the side events reported by parents and in many laboratory parameters. What about results? There were 24 children that were enrolled in that trial. And from them, there were 23 children who completed the trial and were analyzed. There were 30 boys and 10 girls with a mean age of 10 years. There were 12 children carrying a GRIN 2B variant, 6 with a GRIN 1, and 5 with GRIN 2.8 variant. All of these variants were confirmed as pathogenic and functionally annotated by Xavi Altafag and Mireia as a loss of function. The most intellectual disability was the most frequent feature in our cohort of patients, ranging from mild to profound. And even there was a girl with a borderline intellectual functioning. For the purpose of this study, we define intellectual disability according to the Adaptive Behavior Composite Standard Score. Behavior disorders were also very frequent, around 80% of our children. And among them, inattention and impulsiveness were the most frequent findings. And movement disorder were also present in 78% of them, including stereotypies, hyperkinetic movement, and dyskinesia, ranging from mild to moderate. And in addition, there were 62% of our children who had history of epilepsy. In our cohort, in general, they have a well-controlled epilepsy. There were only 2 patients with a refractory epilepsy. And the other were seizure-free with a monotherapy with 1 drug, or even there were some children who are seizure-free without treatment. And there were also 3 patients, all of them GRIN 2A patients, who had an EEE showing a continuous spike and a wave discharge in sleep. That is a typical pattern in epilepsy during the night. And 2 of these patterns resolved previous to the beginning of the trial. Well, about the primary outcome measure, I will start with the Byline-2. The Byline-2, it's a caregiver report measure of the adaptive behavior. Adaptive behavior refers to the skills that have an individual to perform activities that allow his personal and social independence. The Binance score is composed by 4 main domains, and each of them has 2 or 3 subdomains. The main domains are socialization, communication, and daily living skills. And we obtain an adaptive behavior composite with this scale. When we start with the trial, we suspected that the response of treatment can vary according to the patient's severity. That's why we decide to divide patients into, we classify patients into 2 groups, taking into consideration the ABC standard score of the B9-2. So patients who have more equal of 55 points were classified into the mild group, whereas patients with less than 55 points were classified into the severe group. And as you can see here, we notice an improvement for all domains in the mild group, especially with a significant difference for the daily living skills. Whereas into the severe group, we don't find any difference. Daily living skills, for your knowledge, refers, for example, how a child can eat or dresses or manage money or take transportation, for example. That I think that is totally useful for the daily life. And in order to detect even minor changes, we evaluated the different the raw scores for the different subdomains of the scale. And again, we detect an improvement in several subdomains, such as expressive, personal, community, and in the interpersonal in the mild group, that unfortunately not were found in the severe group. But I mentioned before that we assess our patients with a lot of variety of assessments. So this is another test that we use, that the name is the Bailey scale. This is a measure that evaluates 3 main domains: the cognitive, the language, that it's divided into receptive and expressive language, and the motor, that is divided also into 2. And we're using this test that normally, this is a test that evaluates young children from 1 to 72 months of age. But it is also useful for patients with a mental age equivalent of this age. So we use this test in 15 children, especially for the severe group. And using this test, we detected higher scores after 12 months for the cognitive domain. This cognitive domain refers to skills that for memory, for the attention, so they are the basic just for the development. And when we evaluate with other scales, such as the gross motor function measure that evaluates mainly the motor function, and using the PET-QL for the quality of life of patients, we detected for both groups, from the mild and for the severe group, a higher score after 12 months of treatment. Well, about epilepsy, as I mentioned before, in general, our patient had a well-controlled epilepsy. There were only 2 children with refractory epilepsy, But one of these children have a decrease in the frequency and the intensity of seizure after 12 months of treatment. And we also noticed that there were 5 children with intercritic abnormalities in the baseline EEG, no clinical seizures, only an abnormal EEG pattern, but normalized their EEG after 12 months of treatment. And unfortunately, there was one child who had her first seizure during the trial. She has a normal baseline EEG, and during the trial, she had a tonic-clonic seizure. But despite that event, she continued with the trial because parents noticed an improvement in the cognitive skills. And we started levetiracetam, and she was seizure-free during all that time, during the rest of the trial. Well, and we detected also other non-measurable improvement, such with the typical and the conventional scales, such as the writing and drawing, as you can see here in this slide. And from the caregiver point of view, they notice also an improvement in other skills, such as in the social learning and in the nonverbal interaction. They told us also that they start to have a double, to make double meaning jokes and have verbal irony. They improve their attention span and their reaction time. Well, and last but not least, in general, L-Serine was well tolerated. There was only one child who interrupted the treatment. This child is a GRIN to be child who after 2 weeks of treatment have irritability, self-aggression, insomnia, and episodes of hyperventilation, and family discontinued the L-Serine treatment. The other child that I mentioned before is this girl who had her first seizure during the trial. And finally, a third patient who had some dyspepsia, some intestinal problems, but these symptoms improved after a temporary dose reduction with a completely resolution of this problem. So in conclusion, genetic variants in the GRIN gene variant in the gene family are a cause of developmental encephalopathies, producing a spectrum of neurological signs. The functional annotation of the GRIN variants as loss or gain of function is needed for patient stratification and personalized therapies. Supplementation with L-Serine could be considered a safe and well-tolerated treatment option in patients with loss of function GRIN variants. L-Serine produced significant improvement in some domains of the adaptive, developmental, motor function, and quality of life evaluations, and the subgroup analysis suggested that improvements in children from the mild group were greater. And finally, L-Serine normalized EEG pattern in 5 children and the frequency of seizures in 1 clinically affected child, although this finding needs to be confirmed in a larger sample. And finally, we learned a lot with this trial, but at the same time, that opened the door for new questions, for example, about the dose. We use the same dose that is used for primary serine biosynthesis defects, and in general they don't have side events, so we felt confident. But maybe a low dose can be also effective. Then how long they need to stay with this treatment all the life, or maybe 1 year, then rest and then start again. We don't know. Serine acts in other metabolic pathway in the glycolysis, in the way, in the sphingolipids, in pathway, in other ways. So we don't know what happened at that level. Other big question is maybe that patient age and GRIN variant are related with the L-Serine efficacy, and that we need other biomarker, other not only scales, maybe the EEG or other biomarkers. And well, that is something that we need to study more. But well, I think that that is a first step with personalized therapy for our children, that it's a rare disease and don't have many options. So it's a first step. Well, thank you very much for your attention, and thank you, our collaborators.